Okay, now we'll start a little bit of practical work, and I would kindly ask Nicole, one of our physiotherapists, to be the model for the day. And if we can get the camera, if you are able to show what we are doing, we'll demonstrate what the clinical examination looks like, what we do in our everyday practice in the clinic. And if you want to come closer, feel free, please, if you can see better. So what you could see in the paper from Per Holmich, and the paper was from 1999, so 16 years now. It's the best paper that you can find on clinical examination. It more or less covers everything. If you do this in your clinics, you'll probably pretty sure know what's going on. So, but unlike Per, who is an orthopedic surgeon and a hip surgeon, and he starts from the legs, I'm an abdominal surgeon, so I start from the abdomen. First, what we do, we palpate the pubic symphysis. You press, you go a little bit up, and feel if there's any pain on the insertion of the rectus or the symphysis itself. Then we go a little bit higher, distal rectus abdominis, if there's any overload, any pain there. And then move slowly to the side of the rectus abdominis muscle, where we palpate around the external inguinal ring. You can feel the lower edge of the internal oblique and the, basically, more likely than the transversus abdominis, the muscle that Adam showed us in his presentation. Is there any pain there in these muscles? Or a little lower, you can feel the pubic tubercle and on the pubic bone, and the end, the distal part of the inguinal ligament. So we feel, is there any pain there? And basically, at the pubic tubercle, between the pubic tubercle and the rectus abdominis, you feel the external inguinal ring. So sometimes you can find in athletes this area very, very tight from a lot of abdominal work. And when you have enough clinical experience, you can really feel when it's really tight, there's something might going on there. Then, I will not demonstrate here, but what we do, and you could see on the pictures, you invaginate the scrotal skin, and you go through the external inguinal ring, which is right above the pubic bone, the pubic tubercle, and it leads your finger inside in an oblique manner, deep and superior and lateral, and you can almost, it's like 2 to 3 centimeters when you put your finger there and you ask the patient to cough, and you will see, you will feel if there's any bulging there, and also you can feel if the muscles are closing properly, because the internal oblique and transversus, when you're straining your abdomen, they're moving downwards, and they're protecting the bare area of the posterior inguinal canal. If they're not moving properly, if you feel that these muscles are a little weak, it means that this area is subject to, without any support, to the forces from the inside of the abdomen, and then you can have this fascia transversalis moving forward and compressing the structures, especially the nerves there. You do this on both sides, this examination, and then we test the muscles. You can do it with straight legs or knees flexed, whatever you prefer. There's no rule, so we cannot say this one is better than the other. And then if you can go do a sit-up, a resisted sit-up, so he goes up, go, and I push in the other way, and you see if there's any tenderness, any pain in the rectus or inguinal region. Then we do the same thing, like an oblique. This shoulder goes to the other knee. Okay, let's go. Push. Okay, no pain, you're fine. We do the other side. Go. And we put some stress in this area and see if it can provoke any pain. But you have to have in mind that this is just one part of the examination. If this is clinically, the patient is pain-free, that doesn't mean that he doesn't have pain when he's playing handball or football, because the loads on the field are much, much higher than what we can do in our clinics. So once we did this, we can check the iliopsoas muscle, like you could see on the pictures. How do we palpate the iliopsoas? This one, in the Per Holmich's paper, it was the most difficult test, and they couldn't reach intra-tester or inter-tester reliability, because the muscle, you need to palpate deep down from the superior anterior iliac spine and towards the edge of the lateral edge of the rectus abdominis. And you go downwards and medially, and you ask the patient to breathe in fully and exhale, breathe out all the way, all the way, all the way, all the way. And then do it one more time. You keep the pressure, okay, out, and then try to go a little bit deeper around the bowels. And now, if you can lift the right leg 10 centimeters. And when he does this, you feel the muscle. It needs some training, but you can feel the muscle contracting under your fingers. And you ask the patient if it's painful or not. So the iliopsoas muscle can be injured. It's usually in long distance running, straight running, but it also can be painful secondary in sports like handball or football, etc. Because of inguinal or adductor pain, and the patient is compensating, trying to protect the painful structures, so he's overloading the iliopsoas muscle. It's like a secondary overuse pain. The other place where we palpate the iliopsoas is you ask the patient to lift your leg, stay like this. See? So in this position, you can feel the rectus and the sartorius, the inguinal ligament, so right below the sartorius and the inguinal ligament, you can feel the tendon of the iliopsoas muscle. So once you find it like this, you put the leg down and then ask the patient again, can you lift your leg? And that's where you find the iliopsoas tendon, and this usually can be painful. Okay, so these are two spots, and the third thing we need, if you can come all the way down, so we show that everybody knows the Thomas test. It's a little bit low for me, but I'll try to show you how we do it. So if the pain is in the right groin, wait. First we'll do this. Let's see. So there's no shortness of the hip flexors. His thigh is not going upwards, and then you can put some pressure down and stretch the iliopsoas. See if there's any pain there. And now you can lift your right leg up against my arm and see if there's any pain on resisted contraction. We do this on both sides. Okay, thanks. Go back. And then we go to the adductors. So, like the picture says in the paper, this is the best way. The patient relaxes his leg on your thigh, and you can palpate the most strong tendon here in this region is the adductor longus tendon. This is the easily palpated one. And at the insertion at the pubic bone, this is where the patients have pain usually. And if they have pain here at this insertion, this is the pain. It's like every insertional tendinopathy, it's the most difficult to treat. Then you palpate down, you follow the tendon all the way to the muscle tendon junction, and then the muscle belly, and you can see if there's any tightness, where is the painful spot, etc. We also palpate the gracilis, the brevis, which is a little bit underneath, and the pectineus, which is a little bit more laterally, and see if there's any pain there. Then we stretch the adductors, see if this is painful and if there's a good length of the adductor muscles. And then we test the adductors with resisted contraction. Okay, push inwards and hold there, push, push, push. Don't let me break you, I'll go in the other way. Push, 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 push. And then after 3 or 4 seconds, you go outside and you see if there's any power. So in a trained athlete, it shouldn't be so easy for you to go to the other side. What do you say? So this is a nice point. Now, it has been proven that as risk factors for adductor injuries, the two main risk factors are twofold: weak adductors, like in this case, and fourfold if there was previous injury in the adductors. So we're not magicians. If somebody had an injury in the groin of the adductor muscles, there is a chance he will have it, even with all our treatments, he will have it again. Then we do the squeeze test, and the most sensitive is the one with straight legs, because in this way you stress the adductors and the abdominal muscles at the same time. Okay, push inside, squeeze, and also you assess now with bilateral contraction, the power of the adductors, and see if there's any pain. So when you do the squeeze test with flex knees, like this, you squeeze, you isolate the adductors more when you suspect adductor-related growing pain, but in this position, the abdominal muscles are more relaxed, so then they're not put into so much stress. And then what we need to do, check the mobility of the hip joint, internal and external rotation, and then hip impingement test. This test, when you go like fader, it's testing the hip, but it can also squeeze the iliopsoas tendon or even the adductors, so it can be positive, but false positive for the hip. Then if you suspect the hip, you can go in the more abduction and then test the internal rotation and see if there's any impingement. Okay, thank you very much. That's what we do in clinics, and when we more or less think that we know what's going on, then we ask our colleagues from physiotherapy department to take over and try to help us with the patient.